Hello, my name is Florim Tsutsuli, and in this video I would like to demonstrate to you how I would treat a challenging lesion. The reason I would like to demonstrate this to you is because I really frequently see different operators having difficulties to treat this kind of lesions. I think it's important for us to speak how we can best treat this kind of diseased arteries. This is a 60-year-old gentleman whom I encountered while I was on call. As you can see, we have a relevant stenosis which needs to be treated. And after inflating a non-compliant balloon, a normal non-compliant balloon, you can see that it's actually challenging and the lesion does not give in. This is a decisive moment when you have to think again and maybe rethink your strategy. One big help for any operator is, of course, intravascular imaging. In my center, we mainly do OCT. When you perform OCT in this lesion, then you will see that actually the reason the lesion is not giving in is a ring, a calcium ring, which you need to treat first. The mistake you shouldn't make is to put a stent and then hope it will inflate, because that won't happen. So if the lesion does not give in using a normal non-compliant balloon, then you need a high pressure device, because very often you will see that the lesion will give in with pressure. Now, why not use a normal non-compliant balloon with a lot of pressure? The problem is that even non-compliant balloons, if you inflate them at very high pressure, they actually are not non-compliant anymore. And if you inflate a normal non-compliant balloon at 25 or 30, 35 atmospheres, then you will have an exponential growth of this balloon. And as I have said many times, and I believe this is really an important message for all, vessels are ruptured by diameter, not by pressure. So in my opinion, one should use a open NC balloon, because this is the only balloon where you can go to relatively high pressure without really risking the vessel to be ruptured, because your diameter will not increase exponentially. In addition to assessing the morphology, where you in this case see a lot of calcium, circular calcium, on OCT you see something else which is very important, and that's the size of the vessel. Because especially if you go to high pressures, you want to be sure that the size of the vessel is really adequately measured, so your balloon choice is right, because you want to add a safety margin to your work. And in my opinion, in heavily calcified lesions, what you can do is to undersize your balloon and upsize your pressure. So if I intend to stent with a 3.5 stent after you measure the vessel, then I would usually crack the ring with a 3.0 balloon at very high pressure and not use a 3.5 balloon. You can then still use a 3.5 non-compliant balloon for post-dilatation, but you add a lot of safety to your work by undersizing your balloon and upsizing your pressure. In this case, we went with an open NC balloon, and as you can see, at 30 atmospheres, the lesion gives in. The ring is cracked then on OCT, which you usually confirm after you see that the lesion has given in. You would like to have the cracks confirm the ring is broken, and then you implant a stent. Usually you then post-dilate again. I think this is also very important. We have shown previously in our study that in order to achieve a very good stent expansion, you need a good lesion preparation, and in a calcified lesion that probably must include a non-compliant balloon where you go to high pressure, and of course then a post-dilatation with a non-compliant balloon as well, and then you have a good final result angiographically and an OCT, and most importantly the patient is safe and you don't have any damage to the artery, and you also have with an expanded stent a good long-term outcome.